So my brief is to set the scene, palliative care and heart failure in Ireland, where it began and our earliest lessons. Now I must start by saying that I'm not an expert in this area by any means, but I did carry out a medical doctorate in 2005-2007, where I was interested in the palliative care needs of non-cancer patients in Ireland. So I'm going to share with you some of the findings from that work and also reference some of the international literature at the time. So any good study day starts with a definition, and this is a very simple definition of heart failure: a syndrome of cardiac dysfunction characterized by dyspnea, fatigue and fluid retention. And we know that heart failure is a costly condition, not only for the health service generally, but much more specifically for the patient and for their loved ones. And we know that it's a challenging condition to manage. We know that it's a disease predominantly of older patients who tend to have multiple comorbidities. We know that frailty is more prevalent in the heart failure population than it is in the general elderly population, and we'll hear more about that today. We know that the management of heart failure can involve many complex decisions needing to be made, and again that will be touched on in the ICD part of the day later. And many patients can actually die from non-cardiac conditions, which can actually be quite challenging for the healthcare professionals, but also for the families into their bereavement. So for all these reasons, heart failure is a challenging condition to manage, and therefore we as the healthcare professionals do need an integrated and collaborative approach to meeting the needs of these patients. So we know that palliative care is at the heart of good medicine. We know that the aim of palliative care is to optimise the quality of life for patients and their families. And we know that palliative care has applications across the stages of heart failure. And we know the principles upon which palliative care is premised are as relevant to heart failure as they are to other life-limiting conditions. Now, many of you are coming from the palliative care persuasion this morning, so this lady will need no introduction to you. But for those of you coming from a cardiology and a heart failure persuasion, this is Dame Cicely Saunders, and she's regarded as having pioneered the modern hospice movement. She was a very remarkable lady in herself, in that she was the multidisciplinary team rolled into one person, because she was a trained doctor, nurse and social worker. And she opened St. Christopher's Hospice in London in 1967. And she was personally motivated to improve the quality of life and the end-of-life care for patients at the time. Now, it was never her vision that palliative care would confine itself to cancer patients. But at the time, she was developing a new specialty. She was trying to improve good end-of-life care for patients. And as a result, she was forced to focus on patients that had a predictable terminal phase to their illness. So hence, at the time, cancer probably did have quite a predictable end-of-life phase. So as a result, most of her work at the time focused on cancer patients. But it was never her vision. And you can see from the writing in 1996 that she wrote, "Terminal care should not be a facet of oncology, but of geriatric medicine, neurology, general practice, and throughout medicine generally." But over the years, palliative care did become synonymous with the care of cancer patients. And the specialty came under a lot of criticism by the 1990s, where people were criticising us for the hospice movement being too good to be true and too small to be useful, that we were delivering deluxe dying for cancer patients, and that the vast majority of patients that were living and dying with non-cancer conditions were the disadvantaged dying. So by the 1990s, the palliative care world was actually debating whether we should be expanding our services to non-cancer patients. Now it seems almost strange that we were having this debate, this artificial cancer, non-cancer debate, because actually it doesn't reflect the real life experience of patients. Just because a patient is diagnosed with cancer, it doesn't wipe away all their comorbidities. And similarly, a patient with heart failure isn't immune from cancer. So this was very much an artificial debate, but actually it was a live debate back in the 1990s and the noughties. So as part of my research in 2005, I carried out a national survey of the attitudes of specialist palliative care providers to the expansion of palliative care to non-cancer patients at the time. And I asked them to rank perceived barrier statements. There were 13 barrier statements in total, but these were the top 5 that the specialist palliative care providers at the time were particularly concerned about when they were being asked to consider looking after non-cancer patients. So patients with non-cancer disease have an unpredictable prognosis. The referral criteria for non-cancer patients to palliative care are not defined, and I'll come back to that later. Palliative care services lack non-cancer disease-specific expertise. The numbers of non-cancer diseases that could be referred is just too big, and resources are already limited for cancer patients, so how could we be possibly expected to expand our services to non-cancer patients? So these were very real concerns, even as recently as 2005. And at the same time, there was an increasing body of evidence being produced that actually showed that patients with diseases other than cancer were struggling, that many of their needs were not being met as they approached the end of life. And the regional study of the care of the dying really was a landmark study. It really did highlight the unmet needs of non-cancer patients, and it was the first study that really demonstrated evidence that patients with heart disease had unmet palliative care needs. And since then, there have been a myriad of publications looking specifically at heart failure. And those publications have documented unmet physical, psychological, social, emotional, and communication needs. So our policy document was published in 2001. So this is the national policy document for specialist palliative care. And actually that didn't entertain this cancer, non-cancer debate. It recommended that the services should be developed on the basis of needs and not diagnosis. So that was in 2001. And when I carried out my survey in 2005, 4 years later, still services were not fully open to non-cancer patients. So at the time, as part of the survey, I asked whether services were available for non-cancer patients. And you can see that over 20% of services were confining themselves to only patients with motor neuron disease, HIV, or they would review a referral on a case-by-case basis. So really it was pretty inequitable even as recently as 2004, 2005. And the type of service that was available for non-cancer patients, again, was restricted by some services. So some services wouldn't admit a patient to their inpatient unit. Some services would only provide a once-off medical or nursing visit. And some services only provided telephone advice to the GP. So that's very recently, that's only in the middle of the last decade. And we've also been interested just in the numbers of patients that are referred to services. Back in the 90s and the noughties, the workload, the numbers of non-cancer patients that were being referred to specialist palliative care services were very low. Now, since then, the numbers have increased. And these are the numbers just from 2015 from the service that I'm involved in. So you can see in St. James's Hospital, which is actually a very major cancer centre in the city, about a third of our workload relates to non-cancer patients. But that's very variable around the country. I would be aware of some hospital services where the non-cancer workload would be over 50%. So over the years, the thinking has shifted within the specialist palliative care world. Initially, we were caught in this artificial debate of cancer, non-cancer, and then we started to move on to just look at numbers, the numbers of patients that are referred to specialist palliative care services. And we're still interested in the numbers, but obviously numbers in themselves are not a reflection of the quality of care that patients receive or whether their needs are being met. There is a perception that there are fewer heart failure patients being referred to specialist palliative care services than we would necessarily anticipate. And a paper just published last year from the UK, again, of all the people that responded to the survey, they found that just less than 50% of services saw 10 or no heart failure referrals. And I know from my service, the 2 services that I'm involved in, I think that does reflect my experience. But do numbers reflect the sort of service that the heart failure patients are getting? Or actually, as David Kerr would say, it can't be assumed that lack of uptake equates with unmet need. So therefore, even though we've been quite introspective in looking at heart failure and looking at the numbers of patients we're seeing, it really wasn't looking at what the specialists in heart failure management were doing. So now we've started to look beyond ourselves, because actually a lot of work was being done by the specialist cardiology and heart failure specialists over the years. While we were looking inwardly, they were actually progressing things from their specialty perspective. And we know that the care for heart failure patients has improved very significantly over the last 20 years. Previously, it was ad hoc and very variable around the country, but we now know that the reference standard of care for heart failure patients should be specialist, multidisciplinary, coordinated care, incorporating the principles of patient self-care, education, close symptom and medication monitoring. And we know that if a heart failure patient receives this best standard of care, their outcomes actually are better than patients that are not looked after in a specialist unit. So up until this point, within the palliative care literature, there were lots of limitations to the publications. Many of the studies were retrospective, many of them were proxy-based. There were no studies being done in Ireland, and in particular, there were no studies being carried out evaluating the palliative care needs of patients with heart failure that were actually receiving the best standard of care, this multidisciplinary coordinated heart failure care. So I was very fortunate to be welcomed by Professor Ken MacDonald in St. Michael's Hospital in Dún Laoghaire and his team. And the heart failure unit in St. Michael's was actually one of the first specialist heart failure units in the country. And I aimed to actually start looking at what the heart failure specialists were doing and were they improving the care of their own patients, and in particular, were they able to meet the palliative care needs of the patients as they were approaching the end of life. So the study was to examine in depth the palliative care needs of patients with heart failure and to compare them with a cohort of cancer patients deemed to have specialist palliative care needs. The methodology, it was mixed methods using qualitative and quantitative approaches. And the sampling technique, it was consecutive sampling of 50 heart failure patients that had advanced heart failure, New York Heart Association class 3 or 4, and deemed by the heart failure clinicians to be deteriorating despite optimal medical management. And I compared them with a cohort of cancer patients that were deemed to have specialist palliative care needs because they had been referred to specialist palliative care services. The median age of both groups was similar. And the results were different to the previously published studies. The previously published studies had been, as I said, based on patients that were not getting this multidisciplinary specialist heart failure care. And I found actually that the heart failure patients were not being disadvantaged from a care perspective in comparison to the cancer patients. Actually, they were very satisfied with the care they were getting. Their medical and community supports were similar to what the cancer patients were getting. And they felt that actually their questions were being answered. And when we compared their overall symptom burden scores, their emotional distress scores, and their quality of life scores, both cohorts, they were statistically indistinguishable. Now, within those scores, there were differences. You know, we could see that the heart failure patients had more dyspnea, the cancer patients had more pain, but overall, the overall scores were similar. So this, for the first time, actually started ringing bells with us as the specialist palliative care professionals that actually the specialist heart failure professionals have very significant skills and they can actually meet a lot of their patients' needs. And the heart failure patients were very eloquent. They were really able to identify the aspects of their care that they particularly valued: the close supervision, the medication monitoring, the ease of access to the service, the telephone support, and the fact that they had a name, somebody that they could call a key worker. There was, however, a small subset of patients who were struggling with the model of the heart failure unit at the time. At the time, the heart failure unit, it was very much an outpatient model where patients had to come in to the to St. Michael's Hospital, and there was really very little outreaching from the heart failure specialist to the patient's home. And there was a small number of patients who were struggling with this model. These were the patients that had increasing fatigue, so actually physically getting to the heart failure unit was a struggle. They had emotional distress, some of their carers were getting very fatigued, and the patients were saying, I'm not sure about the heart failure unit now, even though they were very appreciative of the care that they had received up until this point. So these patients were at a transition point in their disease journey where they actually needed a reevaluation of their needs. So really they were at a transition point, or a palliative care transition point. So you can see that there have been many lessons learned over the years. We've moved from the artificial cancer, non-cancer debate. We've moved from just looking at the numbers of patients that we take on. We've moved to looking outside what we do and actually recognising that our specialist colleagues are extremely skilled in what they do. And since then, the national clinical programmes have been developed, and the heart failure programme recommended that patients with heart failure in Ireland should be diagnosed correctly and managed within a structured programme. So when I was carrying out my research, the access for heart failure patients to specialist care was very variable. Now that has improved very significantly since then. And similarly, our own national clinical programme for palliative care has really, over the years, addressed many of the attitudinal barriers that were identified in my survey back in 2005. So you'll remember in particular the second highest ranking perceived barrier was actually the lack of referral criteria for specialist palliative care. Now the programme has developed nationally agreed referral criteria. So it's not a question of the specialist palliative care services saying to each other, should we take the patient on? It's much more about looking at the needs of the patient and determining the appropriate response. But that has moved the debate on so significantly over the last 20 years. The Palliative Care Competence Framework document that has been produced by the clinical programme again has helped all healthcare professionals to recognise that we all have a responsibility to be able to meet the needs of patients, and as they approach the end of life, if those needs are getting too complex, well then maybe that should act as the trigger to specialist palliative care services. And the Palliative Care Needs Assessment Guidance document has also been produced. And you'll remember that palliative transition point where the patients were on their journey, and just the structure of the heart failure unit for those patients at that particular time wasn't necessarily meeting their needs. So this would be a very useful guidance document for the heart failure specialist to be able to look at the needs of the patient at that particular transition point to determine whether there needs to be a reorientation of the care. So we've learned many, many lessons over the years. I think the big lesson has been the importance of integration and collaboration, and that we can only improve the care and the outcomes for patients if we're talking with our cardiology colleagues and vice versa. And yet it's not all rosy in the garden. We still know that some patients die poorly in the Irish healthcare system. We know that from the Good Death report from the Ombudsman, and we know it more recently from the All Ireland Institute of Hospice and Palliative Care, where they published their Let's Talk About Palliative Care survey. And actually, interestingly, there's a theme coming through from that report that maybe the end-of-life experience for patients with diseases other than cancer is not as good as it is for cancer patients. 2015, 2016, that's a little bit of a concern. So, many lessons learned, but many still to be learned, and there are many questions. For patients with heart failure, what is the best method for integrating generalist and specialist palliative care? What components of existing palliative care intervention provide the greatest increase in health-related quality of life to patients with heart failure? And really, these are some of the live questions that are being explored now, and hopefully we'll hear more about that from the national and international research that's going to be presented today. Thank you very much.